We're having the oral abstract presentations, and we're trying to shed light and maybe gain more knowledge. And the next session is on critical care. I would like to present the chair of the session. He's quite a brave man, I think. He's not only a professor of pediatrics, but he has spoken up against arms trade. He has been engaged in emergency medical care of pregnant women and girls. Please allow me to present Professor David Southall.
Thank you.
Welcome.
Thank you very much indeed. Okay, it's an honor to be here and to be asked even to chair some of these very important pieces of work that you're going to hear about now. We have a limited time, so I'm not going to waste any time talking myself, except perhaps to say that one thing I want to stress is the importance of maternity care in pediatrics. We need to integrate, as you just said, it's critical. And it's critical in critical care because I see so many young girls really suffering terribly as a consequence of pregnancy at 12, 13, or even 10 last week in Liberia, 10-year-old with a baby. So if we first start, if we could, we have 8 minutes for the presentation and then 4 minutes for discussion. I will try and keep you to time. Could I first introduce Dr. Lisa Umphrey? Is she here? Oh, there she is. Hello. Who's going to talk about the framework for provision of pediatric care in MSF hospital settings.
Is this on? I feel unbelievably high-tech with this thing on. It's really cool. All right. So as you said, my name is Lisa Umphrey. I'm a pediatrician who is trained in the US, and now I work with MSF France, or the OCP section, and I'm based in Sydney, Australia, with the medical unit there. And I'm going to be talking to you today about a toolkit and framework for provision of pediatric care in our MSF hospital settings. And thanks for the chance to start off this session. It's very nice. As most of you know, I think, but maybe not all of you, in MSF, we have standard ideas about what critical care means, but mainly for adult settings. So in terms of what levels of care we provide, in terms of what resources we need, but really there's nothing like that for children and neonates. Children are in need of critical care in our projects, that's clear. We've seen it with our own eyes when we're in the field, we see it in our data, and then we see it from the medical literature that come from low resource settings like where we work. Just to give you an idea, in OCP, our data show that around 10 to 20% of the kids coming to our projects are coming with emergency clinical signs, and around 80% of them are coming with urgent clinical signs. So that's just to say that we have very sick kids showing up at our hospital. And it can be very disastrous if we don't have a way to deal with these children. And as I said, we don't have anything standard. A study published in The Lancet, the author's here in the room somewhere, I think over here, estimated that around 50% of the deaths in low resource settings occur in the first 24 hours of a hospitalization. So that's just as to show that if we don't have systems in place, we really can't do a lot for these kids. So when people think of pediatric critical care, usually they think about care in the intensive care unit. But in fact, as most of us know, kids in need of critical care present at every level of the hospital experience. And if we're not prepared to provide appropriate care and standardized care at each level of the hospital experience, then we're not going to be able to address this issue of high mortality within the first 24 hours. And just to point out, this may seem like a simple concept, and it may seem like, well, yeah, obviously we need to do this, but it's very difficult to put in place in our field settings. So these are some photos from one of OCP's biggest pediatric projects in Kutiala, Mali. It was my first pediatric mission with MSF, and maybe for some of you as well. And this just shows the different levels of hospital care. It's a pretty typical MSF project, except that it's very big. During the peak seasons, we can have between 300 and 400 kids, and these are under 5 kids. This is not a bigger hospital population. And kids in need of critical care can present at every single level. And as I said, if we're not ready for them, we can't help them. So to address this issue, in 2015, OCP began working on a pediatric toolkit. And the idea was that we would put an in-your-hand tool into the hands of the field workers. And it would be a tool to help them know how to provide pediatric care. Not how to treat malaria, not how to treat shock, but how to provide the care in a way that was specialized for them. We also then came up with a pediatric framework, which is like the instruction guide for the toolkit. And just to give you an idea, between these two documents and then annexes that go along with them, they include things like checklists for medications, supplies, human resources, tools for how to conduct pediatric morbidity and mortality reviews, how to do chart reviews, how to do patient handover. There's really a lot in here. They're very comprehensive. Between the toolkit, the framework, and the annexes, it's about a 50 to 60 page document, so there's a lot there. And I just wanted to make the point, because it's fairly rare in MSF, we had a consensus among the pediatric advisors, the ICU, emergency, pharmacy, and hospital management advisors. So no small feat. We came up with these tools with them in the hopes that we could use the same terminology and the same ideas that exist in the adult world for standardization, and then apply them to the pediatric world. And that was to sort of help with the acceptance of this new standardization process. And this consensus helped us to define and then standardize our recommendations for all of the units that could provide pediatric care in terms of infrastructure, human resources, training and competencies, so what people have to know to work in a particular unit. As I said, the equipment, supplies, and medication, the routine practices that we do in each area, the clinical guidance, so the books, the tools, the protocols that exist in each area, patient safety measures, continuous quality improvement practices, as I mentioned, things like the chart reviews, morbidity, mortality reviews, and then child-appropriate care. And then in terms of the pediatric ICU itself, I think one of the most important standardizations that we put in place were to define the levels of care. These are fairly well defined in the adult setting, again, but not for our pediatric units. So we wanted to define clearly what we meant, and we wanted to classify pediatric units in terms of, and you can see it here on the left, don't worry about all the details on the slide, I don't want you to read them, but just on the left, we wanted to classify pediatric units in terms of the monitoring, the supportive treatment offered, invasive procedures, and supportive services. And the point that I'd like to make, and it looks like I'm missing a box there, but I guess you can see the words. Most of our projects, at least in OCP, are level 0 PICUs. And I think we have to be very honest about that. And that's not to say that we don't want to advance, that we don't want to go on to include more advanced care. But right now, most of our units are a level 0. We are only able to provide very, very basic care. And if we define it, then we can address it and we can move forward. But things that are more advanced, like CPAP, high-flow nasal cannula, continuous monitoring, in our settings, those things will not be successful if the basics are not in place. And so that's why we felt we needed to do this. And that's what the goal of the framework and the toolkit was to define these things and highlight sort of a path that we wanted to follow to improve them. And of course, we know we don't exist in a vacuum. Hospital care is just one tiny piece of the whole healthcare puzzle. You can have the most beautiful, well-functioning hospital in the world, but if everything around it isn't working well, your efforts aren't going to have as big of an impact as they should. So we also are trying to focus on community endeavors such as the seasonal malaria chemoprophylaxis, primary care initiatives, research, things like that. But at least we're starting with the one particular piece, which is looking at the hospital and trying to standardize and give people the support to provide good care all the way through. And with that, I'll say thank you, and I think I'm within time.
Perfect timing. Thank you very much, and excellent work. Could we have questions now? Please keep them very short so everybody has a chance. There's a lot of people here who want to say something, I'm sure. Questions?
Or not.
Okay, I'll start. Professional standards, medical ethics. Have you a place or thought of a place for these in the hospital settings for children?
Yeah, absolutely.
Okay.
I think also most people know, but I know we have a mixed audience, so it's worth repeating. The standard that we try to abide by in our MSF projects is high. We try to make sure that we're providing similar levels of care to our patients that we would want to provide in any setting. And so incorporating the tools like the morbidity mortality reviews, the chart reviews, standard educational requirements, and then also revisions in each unit helps to make sure that we're ethically providing the care that we would want to. But it's hard to find. You don't necessarily find it incorporated normally into these sorts of hospital settings.
Right. Yeah. And the local people that you're working with, I think they can learn a lot from you about transfer of information on that level.
Yeah,
so
definitely.
Right, let's have some questions. She's given you plenty of time. Please.
It was just so clear. There's nothing else to say.
You've still got 3 minutes. Yes, thank you.
Okay.
Thanks so much for the talk. My name is Anya. How do you manage an OCP? So yes, I'm Anya, thanks. How do you manage an OCP to really get this type of information and toolkits really to the people on ground? Like, how do we implement this in trainings, in the PPD, and how do you do this?
Yeah, it's a good question. Actually, I forgot to mention it. So it's a relatively new tool. And I'll just say tool to describe all of the documents, but we've rolled it out now in 3 of our projects and a new project that's coming out in Lebanon. And what we do, we have a team of pediatric advisors who are at the headquarter level, and then we have people that are the link between the field and headquarters, and they're called implementers or mobile implementing officers. And we found that using those people with the field teams or pediatricians that we know well who are on mission, we can give them these tools, and then they can work to put them in place in the field. But this is a framework. It's a toolkit. It's not a, this is hard and fast what you need to follow. So I think the important thing is we come up with the ideas, but then they can be implemented and tailored in the field, and that's what those people that we identify who put them in place are good at doing. Yeah.
Yes, please.
Okay, Ousmane Diaye from Senegal. I want to, a question. Do you always need the agreement of the Ministry of Health when you do that in the field?
Very good question. I can't get into the details and the specifics about each country, but in general, before we start working in a particular area or country, it is done with the knowledge, permission, and sometimes partnership of the ministries of health. And functionally what happens in the projects is if we have something like this that we want to implement, the leaders of the clinical teams, our medical coordinators, our medical referents, they're the ones who are in charge of disseminating the information to the appropriate people, and then making sure that everyone is on board. But it's always a two-way exchange of information, definitely.
Right, thank you very much, Lisa. That was terrific. Thanks a lot. And now, could we have Dr. Mark Lee talking about lessons learned from introducing increased monitoring of high-dependency unit patients in a Kenyan district hospital. Where is he?
Just here.
Oh, there.
Hello.
I need to get my glasses tested. Okay, so 8 minutes, please. I'll let you know when you're coming up. Thank you.
And I'll just interrupt, just saying that it's okay to ask questions in French, and then they can be translated, for example, by Eugène Boujaja. Or me.
Hi there, everyone. My name's Mark. I'm a paediatric registrar from Northwest London. I'm in my 5th year of training. I'm going to be telling you about a project that I did in 2014, and that was in Kenya as part of a program that the Royal College of Paediatrics in the UK runs. It's called the Global Links Volunteer Program. What they do is they place pediatricians for 6 to 12 months in Kenya, Uganda, and Sierra Leone, and recently Myanmar as well. The role of us is really not really service provision, but training, quality improvement, And in return, we have access for paediatricians from these countries to come to the UK and gain some subspecialty training as well. So just to give you a bit of background about the hospital that I was working in. So Narok District Hospital covers Narok District, which is in the southwest region of Kenya. It's pretty large. It's got the population and size of probably Fiji or close to Djibouti. It's most famous for the Masai Mara, and it's predominantly a Masai population. There's a 32-bedded pediatric unit, but obviously there's a lot of doubling up, tripling up of beds. There was a very busy neonatal unit with 3 or 4 babies per cot, and busy outpatients and emergency department as well. Resources were obviously very limited. We had access to full blood count for the first 2 months that I was there. We didn't have Usenis, LFTs. We had malaria screens and limited oxygen supply. So when I first arrived in February, the first thing that I looked at was the mortality data for the pediatric inpatient unit. And as we've heard from one of the previous talks, 50% of deaths tend to happen in the first 24 hours of admission. What I found was pretty startling, actually. So looking at the data, I split the mortalities into less than 24 hours since admission, more than 24 hours, and then more than 48 hours. And actually, for that month of February, 86% of the inpatient deaths were happening more than 48 hours after admission. To me, this was pretty alarming, because in my mind, it implied that we were doing something wrong with our medical management once these patients were stabilized after admission. The majority of these deaths were happening to the HDU patients. So in our ward, HDU patients were grouped in the 2 beds closest to the nursing station. And these were the patients predominantly with pneumonia who needed supplemental oxygen. There was 1 oxygen cylinder which was basically split using an empty saline bottle to distribute out to 5 or 6 different babies. It also included any babies that were requiring fluid boluses for shock. So following on from this kind of startling finding, I decided that I needed to do something about this. And one way I thought would be useful was increasing the frequency of observations for these sickest patients in the HDU beds, in the hope that we might be able to pick up when they're deteriorating and therefore intervene and prevent some of these deaths. So with the help of Sister Kudada, who was the ward matron and also the head of nursing, we decided to implement a change. And I discovered that initially the HDU patients were getting observations once a shift, so once for the daytime shift, once for the nighttime shift, so only 12 hourly. And that was the same number of frequency as the rest of the patients, regardless of how unwell they appeared to be. So over the course of 2 days, we carried out a training session with 2 sets of nursing staff with Sister Kodada leading it, and basically explained to them the reason for introducing 6 hourly observations. And then a month following that training program, I did an audit of all of the nursing charts for all the HDU patients and had a look at the data over a 2-week period. So looking initially at the numbers, there were 32 patients over this 2-week period that were in the HDU beds. And it looks pretty good. 75% were now getting 6 hourly observations as opposed to 12 hourly from previous. I will go into the details of that in a bit more. And then I also looked at the mortality, so starting in February, looking at in April and June, and looking at the numbers and the percentages, it looks better. It looks like the majority of the deaths now were happening in the first 24 hours and not in the more than 48-hour period. The reason I'll go into the numbers at a later point, but I think one thing that needs to be highlighted about this particular graph is that there were a lot of interventions going on at the same time, so you can't really interpret the results. The number of deaths probably in the region of between 10 to 15 per month, but obviously there's seasonal variation. I'd also just started working there. I was the first volunteer in the hospital. There was lots of training, simulation training going on, and I also introduced an early warning system for the parents so that they could flag up to the nurses when they felt that their children were deteriorating. So this is an example of a chart. I don't have an actual picture of one of the nursing charts. So this is a chart of one of the HDU patients. So you can see that at 1 o'clock in the afternoon, there are probably some accurate observations going on. If you look at the rest of the times, there is absolutely no variability in the respiratory rate. It's constantly 50. And every time I turned up on the ward round in the morning, these were babies chugging away with tachypnea, on oxygen, their heart rates apparently were normal, and they weren't febrile at all. So I was pretty suspicious about these observations. So clearly, the matron was doing a good job at 1 o'clock in the afternoon. I don't know what was happening outside of those times. So this got me thinking, what is the reason for these unreliable observations? So the first thing is the high patient-to-staff ratio. In the UK, in a general PEDS ward, this is not even HDU patients, just normal PEDS patients, there has to be 1 nurse to 4 patients. In Narok, where I was working, on a good day, when all the nurses turned up on shift overnight, 1 nurse would be looking after 16 patients. There was no matron overnight, so no supervision, and obviously the night staff were predominantly doing night shifts. They didn't come to the training sessions during the day because they didn't really feel there was much of an incentive for them. I've included a picture of the UK doctors striking. I'm sure most of you will probably have heard about the recent junior doctor strikes and the upcoming ones in October, actually. I'm sure our reasons for striking are adequate, but clearly not as good as the ones of the doctors in Kenya who hadn't been paid for 3 months on end, and same with the nurses. So there were regular strikes going on, very poor morale in the hospital. And the last point is that MOI stands for medical officer intern. There was usually 1, maybe 2 of these covering the entire hospital at night. So that includes emergency department, adult medicine, surgery, obstetrics and gynecology. So they weren't around in the vicinity of the pediatric ward, and they were usually contacted via mobile phone. So I'm sure there was some reluctance from the nurses to contact the MOI overnight because they knew they were very busy, and they had to prioritize where they were going. So in terms of recommendations, I mean, clearly there needs to be more training, particularly of the night shift staff. It needs to be repetitive training and ongoing. I'm lucky in that there are further volunteers being placed in this hospital from the Royal College of Paediatrics, so they're able to re-audit all the work that we've done and see whether there's been any improvements. And the last point is this picture here is an example of an early warning observation chart from my hospital in the neonatal unit. And the way it works is that if you have any observations in the yellow, then you're meant to repeat them and then notify your senior nurse or one of the junior doctors. If you have any observations in the red area, then you have to escalate it straight away to a junior doctor. And I think this would be a useful method of empowering nurses to say, yes, they're triggering on the chart, so I have to call you and you have to come and review this patient. And hopefully that will reduce the mortality in some way. So thank you for listening. I have to answer any questions.
Thank you very much. Great. So that was, again, perfect timing. Questions, please. Could I just bring in a point that was made by the gentleman from Senegal? Do you have any contact with the Ministry of Health concerning the nursing standards and medical standards in that hospital that you can advocate for?
So we're very lucky in that the Royal College of Paediatrics has a good partnership with the Kenyan Paediatric Association, and we regularly met with the head of paediatrics for the entire country, and part of our job is producing a report, and I detailed all of this in my report to the head of paediatrics. So they're very much on board with it, as were the head of nursing and the ward matron, so very cooperative.
Yeah, human resource management is the massive problem in all of these hospitals, actually. It's terrible. Okay. Yes, please.
Hi there, my name is Cindy. You mentioned something about an early warning system for the parents. Can you briefly just explain what you did there?
Sure. So I adapted ETAP Plus. I'm not sure if everyone's familiar with that. It's emergency triage and treatment protocol that the WHO uses, and is loosely based on the FEAST trial as well. So using the ETAP Plus guidelines, I pulled the most common signs and symptoms for airway, breathing, circulation, disability, and put them into a poster. And every time a patient was admitted, the clinical officer that was admitting them had to explain the early warning signs to the mum in whatever language, Kiswahili or Kimasai. And the aim of that was that it would just kind of allow the parents to flag up when they felt that their kids were deteriorating. And in addition to that, there's also the added bonus that when they're finally discharged, they have a bit of knowledge about red flag symptoms in the community so that they can then approach their community health worker if they have concerns.
Bonjour, Mariam Silla du Mali. Ma question, c'est par rapport à la pérennité de ce que vous avez fait. Parce que c'est vrai que tant que le problème de ressources humaines n'est pas réglé, si vous êtes là, les infirmières ont peut-être la motivation, mais après, qu'est-ce qui va se faire si vous ne réglez pas le problème de ressources humaines?
So my French is very, very rusty. I'll need someone to translate for me.
Yeah.
Yeah, we have a translator.
Mine's worse.
This is Dr. Ann Lindstrand, former MSF president in Sweden, and also knows French better than I do.
All right, the question was about the sustainability, the capacity to carry on what you started. Because when you're there, motivation is there, and help and so on is there. What happens afterwards?
It's a very good question. So as I mentioned, we're quite fortunate that we have received funding from FET to continue placing Global Links volunteers from the UK in that particular hospital. But how long that funding is going to continue for, no one really knows. So what we tried to do was, as with ETAP Plus, which was being rolled out throughout Kenya, is you have a local ETAP Plus champion in that hospital, whether it be one of the medical officers, or usually it's likely to be a nurse because medical officers tend to rotate and move on from the hospital. So what I was trying to do was actually get Sister Kodada, the ward matron, to really lead on this so that when the point comes that we no longer place doctors there, she's able to continue the work. And it's probably best to have a local nurse, a local MSCAI nurse to really be in charge of programs like this.
A short question, Dr. Wester from Karolinska Stockholm, but I don't really understand, how did you achieve the effect? You didn't get more staffing, but was it a change of morale in the staff? When you had this triggering, did they call the medical officers in-house more often, or how come you saw an effect?
I'm not really sure why I saw a reduction in the deaths after 48 hours. It's probably a combination of all the other projects that were ongoing, the ongoing teaching, and probably because I was there. I'm not sure there was a lot more triggering overnight because as I looked at the charts, there wasn't, the observations weren't being done properly. So I'm not sure that, I don't think this project was successful.
Sorry, we have one more. I think you were probably first on the list. Maybe I'm wrong. I don't want to cause any difficulties. Let's go for you. Yeah. One more question.
My name is Jaap Karsten. I work in Amsterdam. I love the PEWS, the Pediatric Early Warning Score. Are there any published data already in our low resource settings that it really works, that it can reduce after admission mortality?
I have to admit, I don't know about data in low resource settings. I'm not sure if anyone else in the audience knows.
I don't think so. I don't think so. No, I may be wrong, but I don't think so. Well, thank you very much, Mark. Thanks a lot. That was great. Thank you very much. Dr. Lang. Hello. Oh, there he is. Bubble continuous positive airway pressure and the management of critically ill children on a busy pediatric unit in Malawi. Thank you very much.
Okay, thank you very much for inviting me to present our very modest observational study on the use of bubble CPAP in Malawi. How do I move on? Ah, okay. So respiratory failure in children can be caused by severe respiratory infections, but obviously can also occur in the context of critical illness, sepsis, the sepsis syndrome. In low resource settings, respiratory failure is associated with a high mortality risk. On the other hand side, respiratory support is an essential element in critical care. Different forms of non-invasive ventilation exist and are routinely used in high resource settings. NIV, non-invasive ventilation, does not only have the potential to improve outcomes of children with single organ failure, pneumonias, but also might play a role in the context of management of critically ill children with multi-organ dysfunction. Previously, in 2012, we conducted a little study in Lilongwe, Malawi, using a very improvised setup to provide bubble CPAP. And in this case, in 2014, we have the chance to use a more adapted form of bubble CPAP. The study was conducted on a busy pediatric unit in Lilongwe with more than 20,000 admissions per year. We conducted the study between February and April 2014 during the malaria season. We used modified oxygen concentrators. I come to that, back to that in a moment. And sometimes, if we didn't have enough CPAP setups, we used oxygen cylinders to provide the air oxygen flow for CPAP. We recruited children with severe respiratory dysfunction between the age of 29 days and 59 months. We defined bubble CPAP failure as death during bubble CPAP treatment and within 48 hours of bubble CPAP weaning. Only very eventually we had the chance to intubate and ventilate children in the hospital's intensive care unit. The study was approved by the Malawi National Health Science Research Committee. Following up a bit on what Lisa said, our critical care pathway consisted of a triage unit, an emergency resuscitation zone, and what we called a centralized critical care zone. And then we had all the other elements important for pediatric department. We managed children according to WHO guidelines. Following the FEAST study, we were a bit more careful with fluid resuscitation, and we did not give pre-transfusion boluses to children with severe anemia. Other conditions were managed according to WHO and national guidelines. We had massive resource limitations in terms of human resources, supplies, equipment, maintenance. This was our bubble CPAP setup, oxygen concentrator used to biomedical departments in MSF. It has an oxygen outlet with 10 liters per minute and an air outlet with 10 liters per minute. So altogether 20 liters per minute flow per minute. The air oxygen flow can be humidified and somehow heated with the help of the warmth produced by the compressor of the concentrator. The pressure is determined in bubble CPAP by the distance of a tube below a water surface, and then we have the interface with the child. We started usually off with a bubble CPAP pressure of 7 to 8 centimeters water, and we adapted FiO2 according to the saturation of the child. We did basic critical care. I think I need to speed up a bit. Monitoring on a very busy unit, we just did basic internal triage, basically eyeballing the children, and we managed to do at least 2 vital signs rounds per day. That doesn't seem to be very much, but in the given context, that's what we were able to do. Our bubble CPAP weaning protocol, we reduced oxygen FiO2 if the saturation were consistently above 94%. We reduced the pressures if saturations were stable and work of breathing and clinical condition improved. We took children off bubble CPAP if respiratory function stabilized and saturations were all right, and we then placed them on 1 to 2 liters per minute low flow oxygen. The objective was to maintain saturations above 94%, and that's consistent with the latest WHO ETAT guidelines for children with respiratory dysfunction associated with other organ failures or organ dysfunctions. We had 115 patients in total. 64% of these children survived, and keeping in mind these were children with severe respiratory dysfunction, but also severe respiratory dysfunction and other organ dysfunctions. I will come back to that in a moment. The median age was around 8 months. The survival among children with single organ failure was 86%. Children HIV exposed or infected had a higher mortality risk than non-infected or non-exposed children. In a little subgroup, we didn't have many patients, so it was our subgroup analysis was limited. In children with single organ dysfunction, no other comorbidities like congenital heart disease, etc., and HIV negative, the survival was 94%. However, the numbers were pretty low. As soon as a child had further organ dysfunctions like signs of shock, anemia, or more than one organ dysfunction, mortality was increasing. Malnourished children had a higher mortality risk, and most of them had more than one organ dysfunction. Conclusions. The limitation of this study, it was just a basic observational setup. We had a relatively small number of children, just 115, and the quality of our data collection was affected by the enormous workload on the unit. The cohort we evaluated presented children with very high mortality risk. However, we didn't use a disease severity score. The subgroup of children with one organ dysfunction and no comorbidity, HIV negative, the high survival rate shows that we can use bubble CPAP in low resource settings. And the outcomes of this subgroup was comparable to outcomes of a recent randomized controlled trial conducted by Kristina and Trevor Tuke in Bangladesh. The role of bubble CPAP can play a role in an improved care package for critically ill children in low resource settings. However, as Lisa outlined, we first need to do the basics very well. And NIV can play a role if we apply advanced levels of critical care.
Thank you very much.
Thanks.
This is a very important technique, there's no doubt, including in neonates with respiratory failure. So thank you very much for bringing it to this meeting. It's really important. Yes, please.
Frederick Sorge, thank you very much. I think it's also a very good technique to develop. I have two questions. This type of techniques needs human resources to follow up the help that it brings. What is the cost of this bubble CPAP, and what is the energy you need to make it function?
Okay, the energy I would have to ask a biomed electrician, but you're right. The cost of these concentrators is around 1,500 euro, but the cost of a normal concentrator is maybe a little bit lower. So it is not that much higher than an oxygen concentrator providing 10 liters per minute of oxygen. It's correct to use it like any oxygen system, even low flow oxygen, we need a good electricity backup. So we cannot only rely on a national grid and need a reasonable backup.
Thank you. Next, please.
Was it me?
Yes, you.
Oh,
yes.
sorry, I thought
sorry.
you were looking down.
Sorry.
Just to add to that, we've been putting, and we now have in all the district hospitals in Malawi, what's called a Pumani. It is developed specifically for low-income settings. It costs about $800. It is separate from the oxygen concentrator, and I rather like that because it means if one doesn't work, you've still got the other one, whereas if you've got it all in one, you've lost them both. It is designed more specifically for babies under 10 kgs, particularly neonates.
Thank you. Next at the back.
Thank you. I'm Wilma van der Boogaard from MSF. I just have a question with the results you're having and with the the very crowded pediatric ward and the lack of staff. Would you consider that we should have this, if we talk about low technology neonatal care units, would you consider this we should distribute in all our settings with the capacity, thinking of its capacity and its feasibility?
Well, I think we are coming back to these levels of care described by Lisa Umphrey. Like for children, we need to sort out basics well, doing triage, emergency care very well, and define, let's say, a critical care unit. And I think once we are very good in doing this, we can step up. I think the potentials of using bubble CPAP will not be fulfilled if we just do it on a normal unit. And the impact will be limited. And I think the same applies to neonates. I think, again, basic, essential neonatal care needs to be established first. And then, if that's done very well, we can think about using CPAP.
One final question, please. Thank you.
Okay. I'm sorry, but I don't speak very well English, so I'll speak...
Je parle un petit peu français,
okay,
si vous voulez.
Okay. Merci, je suis très intéressée par ce système. Et ben, la question que je me pose, est-ce que dans les hôpitaux au Malawi, il y a une fourniture régulière du consommable? Parce que nous, les tubuleux, est-ce que c'est peut-être de les utiliser plusieurs fois? Est-ce que c'est à usage unique?
Could you repeat just the essence?
Donc, the question was, if my French is good enough, so first, is there a supplier, a local supplier in Malawi or elsewhere? And what about the consumables? So I think a very good question, une très bonne question. And so we had a supplier based in the UK, but I think that's certainly a challenge. And if that's established in a unit, I think supplies and maintenance and repair needs to be sorted out. Otherwise, it cannot be sustained. The consumables, we probably didn't do it well enough for MSF standards, so we washed the tubings. And so again, in a program which uses bubble CPAP, we need to decide how to deal and how to reuse consumables. Yeah.
Yeah. Yeah. Just one quick one, please. Thank you.
Hello. Hi. Thanks, Hans, for your fantastic presentation. And I think it's something that we're all extremely interested in, especially after all those discussions on shock, etc. But we all agree that the basics, as we keep repeating, have to be in place first. Do you think that the basics were in place where you put it in place? And because, you know, like we all agree that the basics need to be in place, but we never know exactly what we're talking about when we say the basics. So I was wondering whether, with your retrospectively, now that you've done it, you think that the basics were good enough to put it in place, or you would not redo it with those basics yet in place? I don't know if my question makes sense.
Yeah. Well, I guess in our setting, I would say the basics were in place 75%. So maybe not just exactly, but we were just intrigued by it, and we couldn't resist starting using it. And so I think if the team is motivated and keen, and the nurses take it on board, then it's probably easier to do than one thing.
Yeah. I think there is another one crept in. Just very quick, please.
Merci, je vais parler en français.
Oui.
Voilà, en fait, quand vous avez donné les objectifs visés par la CPAP, c'est des objectifs de saturation supérieurs à 94% pour une FiO2. Moi, la question que je pose, c'est par rapport au monitorage de cette FiO2. Parce que parfois, vous parlez de FiO2, parfois, vous parlez de débit. Et on sait que sur ces appareils-là, on n'a pas de FiO2, on n'a que les débits. Comment vous faites? Est-ce que vous avez un tableau de correspondance?
Oui.
Ou bien est-ce que voilà? Merci.
Donc il y a une table de correspondance.
Just repeat.
I just repeat.
Very quick.
Okay.
Very
so
quick,
the question was, how did we set flow? So we set flow by setting the flow and the oxygen and the air outlet. And how do we monitor FiO2? So there was a table basically. So at the outlet of the oxygen outlet of the concentrator, we have a concentration of roughly 95%. And then depending on the outlet or the mixture between air, oxygen, we then can determine the FiO2. And I guess that's particularly important in neonates. Yeah.
Thank you very much, and thank you for the questions. Really very important. Thanks. Okay, the final abstract presentation is from Dr. Mwanga, and she's talking about the management of cerebral malaria in children in resource-limited settings, 2 trials. Thank you very much.
Thank you very much. Good morning, everybody. So I'm Juliet, and I'm a pediatrician. I work with Epicent, and I'm based in Uganda. So Epicent, as you all know, is the research arm of MSF. So we do research, of course, that should make a difference. And among these researches, we've done several in malaria. Most so because, as you all know, malaria still remains a big cause of mortality, and more so in sub-Saharan Africa, where up to now 90% of the severe forms of malaria occur. And you also probably all know that cerebral malaria is the most severe form of malaria. And despite the many studies that have been done, and despite the many treatments that have been discovered, mortality from cerebral malaria per se in children is still high at 18%. So because of this, we continue to do research. And so today, I would just like to share with you a short experience comparing 2 clinical trials that were run in collaboration with, by Epicent, in collaboration with other stakeholders. And in particular, we shall look only at the mortality. So as really for methods, I just merged 2 data sets from the 2 different clinical trials, just to compare the characteristics of these 2 clinical trials. So there was the Aquamat that was run from 2007 to 2010. It was a multi-country, multi-centric study, and we were lucky to be part of the sites. So the data I will share today is specific to the site in Mbarara. So the Aquamat study was in severe malaria, the whole spectrum of severe malaria. And the children were aged 2 months to 12 years. It was a clinical trial. It was open, block randomization. And it was testing the effectiveness of artesunate compared to quinine. And as a result of this study, because the results were very good and there was a significant reduction in deaths on the children who received artesunate compared to quinine, the policy was changed for treatment of malaria. And as you know today, artesunate is the first line for severe malaria. The other study followed shortly after as a result of this, because among the whole spectrum of severe malaria, children with cerebral malaria were still dying despite the new treatment. So Epicent, in collaboration with collaborators from the US, decided to study the role of inhaled nitric oxide as an adjunctive treatment to see if this would reduce the mortality from cerebral malaria per se, because all the other severe forms of malaria had reduced, but cerebral malaria still remained with a very high mortality. So we again looked at children aged 2 months to 12 years. It was again open, block randomization. And in this particular study, all children received artesunate. But on top of the artesunate, there were 2 arms. One arm received either inhaled nitric oxide as an adjunctive therapy, and the other arm received, well, just air, just a placebo to be able to compare scientifically. And this study followed just 1 year after the Aquamat study. So this table here just shows the baseline characteristics of the children who we looked at. And as you can see that almost, trying to see basically the different methods and eventually what we shall see as probably the cause in the different mortalities. So in the AquaMat trial, and this was the objective of the AquaMat trial, the children were treated on the general pediatric ward, really in the usual settings in a busy hospital, as you've heard from the very first speaker, how busy the hospitals are. So on the general pediatric ward, compared to the INO, where the children were nursed in an intensive care. So a modified intensive care, not really a high-tech, but just show that the intensive cares in the resource-limited settings can also be limited to be able to look after the children well. So on the general ward, of course, oxygen was only available once in a while. However, in the INO study, it was available all the time. The nurse-patient ratio was 1 to 5, sometimes up to 10, and these were still study stuff because it was the whole range of severe malaria, compared to the INO ward where there were really so many staff because they were all just dedicated to the study. So sometimes you had 2 nurses to 1 patient. The monitoring was done 6 hourly in the AquaMat trial because the protocol said so. While in the INO it was continuous because we had gadgets attached to the patient, so the monitoring was real time and the machines beeped and the nurse would run every time the machine beeped. So the beds were shared. We could have like 3 patients in the other trial where the patients were nursed in the general ward, 3 patients per bed, while in the INO ward it was individual patient per bed. And the nutrition in the AquaMat trial, the patients provided their own nutrition. So sometimes it was difficult to feed the children on time, while for the INO, it was provided real time, it was provided by the study, so there was food or nutrition for the child all the time. And the resuscitation, which is very important, as we've been hearing since morning, was given only when the equipment were available, while for the INO trial, it was available all the time when needed. So these were the demographic, I mixed the demographic and clinical characteristics really of the children in these 2 studies. And I would like you to pay attention to the reds. So, because the others were really more or less the same. So when we look at previous anti-malaria treatment, we noticed that in the INO group, the children, more than 80% of the children had been pre-treated. In the AquaMat trial, exclusion of having received treatment for more than 24 hours was an exclusion criteria, so most of the children were left out. Posturing, which is really a clinical sign or probably gravity of how ill this patient is, patients in the INO trial were more ill. Severe anemia, more children in the AquaMat trial were severely anemic because in the INO trial there was pre-resuscitation before enrollment, and many of the children did receive blood before being enrolled. Yeah, and then pH, low pH of less than 7, which is a proxy indicator of acidosis. We note that in the AquaMat trial, around 35% of the children had low pH compared to the INO. And again, just to explain, this is because of the resuscitation that took place in the INO arm. Yeah. So this is the outcome, the mortality, and I request you to concentrate on the left-hand side, the 2 bars on the left. So the first bar compares the mortality in the AquaMat trial, the children, and the next bar is the children who were in the INO arm who received placebo. So in the artesunate arm, we see 18% compared to 15%. 3% looks like a small difference, but in actual essence, really, when you do the relative risk, we find that the difference is 16% in mortality in the children in the AquaMat trial compared to the INO trial. So we tried to do some scientific calculations, really, to find out what could have been the cause for this. So because all children received artesunate, both in the AquaMat trial and in the INO trial, we try to look at the predictors or what could have caused the difference in the deaths in these two trials. So we patched in so many factors, including the low pH, including not having received treatment, including low sodium levels, and so on. But only 2 factors stood out, and that was having a low pH and not having received a pre-admission anti-malarials. So in our conclusion from this, we see that in addition to artesunate, the use is very important to provide enhanced nursing. And really by saying enhanced nursing, it's just doing the basic things, you know, resuscitating on time, monitoring on time, providing fluid carefully. We see that this is the reason why there were less deaths in the INO study compared to the AquaMat study. And this is important because the factors that I showed there, the predictors, 2 predictors, that is the low pH and the giving admission, anti-malaria and monitoring and so on, are things that can be modified by nursing, you know, so you don't need high-tech to do this. Just provide fluid on time, just give blood on time, and you'll be able to curtail the predictors of death. So we recommend, therefore, because these settings are very busy and we do not ask for high-tech critical care, that even if the place is busy, just set aside a corner of 2 or 3 beds where patients of cerebral malaria can be nursed. The good thing is that malaria occurs in seasons, not all year round. So we can predict and tell that in the months of November to December, we are likely to have cerebral malaria, and set aside this corner for nursing these patients. Thank you very much for your attention.
Thank you very much. Thanks a lot. This is really important, and again comes back to human resource management and how this can make so much difference. Any questions, please? Yes. You didn't tell us so much about INO. Just quickly, what's the method? How do you do it? Giving the nitric oxide.
The nitric oxide. So
yeah.
For our study per se, we had the gas in a cylinder, yeah, and we used nasal prongs to deliver. Okay. Yeah. Okay. And we had a small gadget to measure how much gas we were delivering to the baby. Okay. And of course, monitored real time.
Yeah. Right. Thank you. Yes, please.
Yes. I'm very interested what you all included into the adjusted risk ratio. Because if I look at the 2 different study sites, for me, it's obvious that the AquaMat is having all the ingredients to have a higher mortality than the INO study site. Only if I look at the different sites, I could imagine that the mortality is higher. So for what did you all adjust for in your risk ratios?
Okay, so and that is the whole reason for presenting this study, that most of the factors that predict mortality in the INO study were sort of annulled or removed even before the patients were enrolled because of the modified nursing. That's the whole thing. But we included low blood pressure, we included the depth of coma, we included anemia, we included hyponatremia, and all of them did not really stand out as important. So the most significant things with the small numbers that we had were a low pH and not having received treatment before enrollment. And as I said, that was the whole thing, to show that these predictors can be modified by nursing.
Thank you. One final question, please.
Thank you very much, Juliet. I know we have networked in another area, but in Eastern Uganda, my new interest is renal failure or renal impairment in children with severe malaria, all spectrum. I was wondering what the contribution of renal impairment was to mortality in cerebral malaria. Thank you.
Okay. Thank you very much, Dr. Lopot, for that question. So yes, and it is a known predictor, actually. Studies done in Kenya, as Kate will tell us, show that very well, that children with high creatinine and high blood urea nitrogen were more at risk in the study. And in this study, in the INO study, as you saw, the children on the INO study actually had higher blood urea nitrogen, above 40, compared to the 20 in the children with the AquaMat. But nevertheless, when we punched it in also, it did not stand out as important. And I think this is because of the care, as I said, still, you know, giving fluid and assisting the kidney to work before, you know, before even you start giving your artesunate and so on. So it is the nursing care, again, that I'm emphasizing here. The touch, the personal touch that you give the patient. Yeah.
Right, thank you very much, Julia. Thanks a lot for that. And thank you to all 4 speakers for really doing well on time. It's a difficult one, and thank you.